I put myself as the last speaker to be a bit flexible with the time. We have listened to many interesting presentations, basic science, clinical science, and as you pointed out, in the end, it has to translate into clinical care, e-health trials. This is the future. Cardiologists in Sweden are trying to do the same, follow-ups based on registers only. So, I'm going to address new guidelines and give you just a brief overview because we are waiting for some new guidelines, as you know, and it could be helpful if you know something about the background. I will not go into the details, just touch briefly upon them, because I think in the end, our colleagues, ourselves, we need these guidelines. Of course, we have to take into account that the individual patients need individual treatment, personalized medicine, stratified medicine, but we also have to respect that a lot of people work with the guidelines, and in the end, that we can benefit from them. So I'm going to talk about the role of new guidelines and why we need them, not for being forced to follow them in every aspect, but for educational purposes and to support evidence-based medicine and good clinical practice. This is an overview of some recent guidelines published or about to be published during this period, 2009 to 2013. 2009, we had the reappraisal of European Guidelines on Hypertension published by our society. In 2011, came the document Dyslipidemia Management. In the UK, the NICE document in 2011 addressed hypertension, an update. Last year, we had an update on the treatment of type 2 diabetes, jointly published by the American Diabetes Association and the European corresponding organization. In May last year, we also had this joint European guidelines on cardiovascular prevention, published by the European Society of Cardiology in collaboration with 8 other societies, including the European Society of Hypertension. Early this year, we had the Standards of Medical Care in Diabetes published by American Diabetes Association. What we are waiting for now is the presentation next Saturday in Milan, the ESH, ESC, Joint Guidelines on Arterial Hypertension. For those of you who come to Milan, this will be a great moment, a very interesting presentation. In September, we will learn about the ESC, ESD, update on risk factor control in diabetes, including hypertension. And by the end of the year, hopefully, finally, the GNC8, now called the GNC 2013 document on arterial hypertension. So I will just give you a brief overview. Why new guidelines? We need this update of scientific information. Of course we do, and our colleagues would like to read something comprehensive, something easy to understand and focused. We need also to strengthen international collaboration. As you know, the WHO has pointed out that hypertension is the global killer, the most important risk factor on a global scale for mortality. And that is why we need to strengthen the collaboration, not only within Europe, also with developing countries, China, India, Africa, other continents. I can tell you that already now we have received to the European Society of Hypertension several emails, several letters from Chinese colleagues wanting to collaborate with us to translate and to implement some of the guidelines recommendations. So that will happen later this year. There is also need of guidance for national guidelines. But we have to remember, as is often pointed out by our society, that our guidelines are in essence educational but not prescriptive, because individual national societies have to take into account specific background factors in their individual populations. So it isn't the case that one shoe will fit all feet. Individual countries have to adopt what is useful. Quality standards for practice evaluation. Cardiologists are running the EuroAspire service, as you know, and we would like to see something similar also related to control of hypertension. So just let me give you two examples based on what has been published in the guidelines. Goals for blood pressure control in diabetes. You know it's a hot topic. And going back to the 2009 reappraisal of European guidelines, the goal for systolic blood pressure in type 2 diabetes was set to be less than 140 millimeter mercury. And that provoked a lot of debate, even a shock to some colleagues. Why do you change your opinion? The previous recommendation was less than 130 millimeter mercury systolic blood pressure. Well, the answer was the evidence is not sufficient to really state anything else. But people were not happy with this, at least some people. In the UK, in August 2011, came the updated NICE guidelines on hypertension. Mark, you know it very well. You participated with other British colleagues. And the basic recommendation was to go for less than 140/90 in people aged under 80 and less than 150/90 in 80-plus people. No specific recommendation on patients with diabetes, but that applied also to, I guess, different risk categories of patients. So this was a more simplified way to look upon it. But you also recommended a more widespread use of ambulatory blood pressure recordings. And my personal view is that this is specifically important in patients with type 2 diabetes, as so many of them have masked hypertension, as we all know. So that was the British view. Last year was published in European Heart Journal this joint European guidelines on cardiovascular disease prevention. Please notice that Jo Perk, first author, is a Dutch cardiologist living and working in Sweden, so there was a Swedish influence somehow. And they came out with a recommendation to go below 140/80 millimeter mercury in patients with diabetes, with a strong grade of evidence. Let's cross the Atlantic to United States. For many years, the American Diabetes Association usually publishes standards of medical care in diabetes. And for a long time, they kept the old, so-called old, recommendation of a blood pressure target in patients with diabetes of less than 130/80 millimeter mercury. I attended the ADA Congress in Philadelphia last year, and we had a discussion, European views, American views, and I was quite intrigued to read this year's edition of Standards of Medical Care, published in January. And in fact, they changed, not completely, but one step towards the European view, because they now accept the goal of less than 140 millimeter mercury in most patients, but of course in younger patients, newly detected patients with diabetes, we can go for a more ambitious risk factor control, and they keep the lower target. For diastolic blood pressure, they mention less than 80. The nephrologists in the United States have recently presented guidelines also addressing blood pressure goals in patients with chronic kidney disease. George Bakris, the former president of the American Society of Hypertension, and other colleagues, they keep the view that if there is macroalbuminuria, we should recommend less than 130/80. But if there is microalbuminuria only, the goal should be less than 140/90. This is still debated, and not everybody agrees with that. So next Saturday will be presented our new updated guidelines for the management of arterial hypertension. I cannot give you the details, but I can assure you that many people work together to finalize these updated guidelines. I think it will be of major importance for the debate, not only in Europe, but also in contact with other societies from other continents. In September, we will learn more about the updated document, guidelines on diabetes, prediabetes, and cardiovascular diseases, risk factor control in patients with impaired glucose tolerance, impaired fasting glucose, and established type 2 diabetes. This is led by Professor Lars Rydén with a UK colleague and a large group of people working together. So I had the chance to read the document, being one of the reviewers, and I also tried to facilitate some context between the different writing groups for the hypertension guidelines document and this document, because it's important to know about opinion of the others, so that they will be more conform and not divergent. This is important to have a strong message, common message. Everybody is asking about the GNC 2013 document. It has been in progress since 3 years. The previous version, GNC 7, took only a few months to finish. This has taken several years. And it's not a full set of guidelines, please notice. They only try to focus on 3 questions, as indicated here. How low should you go? Blood pressure control, when to initiate drug treatment, and how do we get the different classes of antihypertensive drugs. This is still a work in progress. Optimistic people tell that by the end of this year we will learn about it. Pessimistic people tell that maybe we have to wait for next year. Just a few days ago, May 21st, the American Society of Hypertension held its annual meeting in San Francisco. And there was an interesting quotation that I picked up from the web, that some people think that it's better to have a common blood pressure target for all patients, because it's easy to remember, less than 140/90. This is not the final document. It's just based on the debate in San Francisco a few weeks ago. So we will learn more about that in the future. But as you can see, this is a way to try to simplify the message, because hypertension is a global problem. There is a need for simple messages on the one hand, public health interventions, but on the other hand, what Mark addressed, advanced bioscience, translational research to find the new ways. So we have to move forward on 2 legs. Basic science, translational research, everything. But on the other leg, move forward for public health interventions, simple things. Beetroot experiment, I like that very much. Second example, lipid control. Everybody knows that research has been ongoing for many years now. Statins came in the 1980s, and we know what happened based on data from many trials. In 2011 was presented this guidelines document for the management of dyslipidaemias, not for hypercholesterolemia, not for hyperlipidemia, for dyslipidemia, because that linked also to metabolic syndrome, to insulin resistance, to impaired glucose metabolism. And a lot of people work together for this. This is just one quotation. to show you the goals for reduction of LDL cholesterol, different classes of evidence, different levels, as you can see here. But in essence, the higher the risk, the lower should be the goal for LDL cholesterol reduction, based on statin therapy, in some cases also based on combination therapy. If we move on to the 2012 document, the Fifth Joint Task Force of the European Society of Cardiology and other societies presented about a year ago. There was a similar table showing you the evidence for controlling LDL cholesterol and also some specific indications in certain risk groups. So the statin story has been successful, as you know, even if some people experience side effects. We know that now there are also genetic markers available to find out who is susceptible for this myopathy. And in one university city of Sweden, in Uppsala, the Department of Clinical Chemistry is already offering clinicians to do this test if they have risk patients where they consider the risk of adverse events. In the Lancet last autumn was published this updated meta-analysis based on individual data from trials included in cholesterol treatment trialist collaboration. The interesting point here is that the benefits of lowering LDL cholesterol based on statin intervention is also seen in the low-risk group. And of course, this is an ethical and practical and clinical very hard question. I think, my personal view, is that the only solution to this is the polypill strategy, and to offer anybody willing to take a statin for any reason he or she can find out, to buy it for themselves and to use it, and only to have contacts with clinical care with physicians if there is a suspicion of adverse events. So to make it easier over the counter, buy your statin if you like it, because in fact there is a reduction of cardiovascular event risk even in the low risk category. And of course the primary healthcare sector will be overburdened of too many patients if we go for that strategy. So this is why I've come to think of this polypill strategy and to let the statins free. Of course, with some added information how to behave if you experience any adverse events and so on. Early this year came a very, very important document, the Cochrane Institute Review on Statins for Primary Prevention of Cardiovascular Disease. This is not guidelines, but it's a cornerstone for future guidelines. Because what was written here is that all-cause mortality was reduced by statin therapy also in the primary preventive clinical situation. Relative risk reduction 14%, absolute risk reduction much less, of course much less. And in the general population, I think if we put together the findings from the Lancet paper last year with the Cochrane review this year, in the end, let people, adult people, elderly people, have the choice of their own. If they want to take a statin, let them do it. No physician involved. Let them buy it, let them use it if they believe it, and it might even save a few lives. If there are side effects, of course they should be advised to seek medical care. There might even be serious adverse events in a few people. And you have to provide the information, of course. Statins can increase hyperglycemia. It's well known. Research going on at this hospital, basic science, research has described that if you isolate beta cells in vitro and you manipulate the cholesterol content of the fluid media, there will be changes in the insulin secretion rate. That might be the mechanism. So it's there, it's an adverse event, but of course, as you all know, the benefits overshadow this adverse event. However, we can learn much about pleiotropic effect by this finding, and a project is running right now at this hospital to find out more about why. Finally, just to touch upon what other speakers also addressed, the failure of HDL increasing drugs. There have been 3 major randomized controlled trials over the last year, all failures for millions and millions of dollars, trying to increase HDL cholesterol levels 30–40%, no effect on cardiovascular risk reduction. This is one of the studies, niacin versus placebo, no effect. This is the other one, dalcetrapib, one of the CETP inhibitors. There is also one additional niacin study. They all failed. And if Mendelian randomization analysis could have been applied beforehand, lots of dollars could have been saved. Finally, just a few words about glycemic control. This is really the Scylla and Charybdis. If we treat hyperglycemia, there is also risk of hypoglycemia and even some adverse effects. And you know the modern message is really to individualize treatment, and in the elderly, you have to be very careful to avoid hypoglycemia and adverse events. This is the algorithm presented last year by ADA and EASD. You start with metformin and lifestyle, and then you can continue like this. The new incretin drugs are promising. The first large-scale randomized controlled trial, SAVOR, saxagliptin, has been stopped, and results are awaited by the end of this year. A cardiovascular risk reduction, endpoint reduction study. It will be very, very important because that will also cast some light or shadows on the other trials. You know what happened yesterday in the United States? FDA held a meeting discussing rosiglitazone based on a re-adjudication of the record trial data. There was a vote, and they have reduced some of the limitations, some of the bans previously imposed on rosiglitazone because the re-adjudication of the record trial data showed no increased risk of cardiovascular endpoints. Check on the web, you find out. It's very fascinating how the FDA is moving now, and they have open meetings on this and an open vote. This is not to say that rosiglitazone will become a big drug, but you have to rely upon evidence, and evidence should be discussed, and then there was a vote. So in summary, I presented a number of new guidelines to you. We are waiting for 3 important documents. We need them to have this evidence-based guidance for clinicians, but in the end, we also do have an understanding that during the consultation, you have to evaluate the individual needs of an individual patient, and sometimes it's not good to prescribe any drug. Sometimes it's what we can recommend. But to listen to your patient and to try to find out what is appropriate is, in essence, clinical practice and clinical mastery, I would say. So, finally, I see a trend for less divergent views on risk factor control and treatment goals across the Atlantic. So, Europe and America are coming closer like this. This is my view. Thank you very much.